artery.
Yeah, I have not changed anything from the open to the laparoscopic approach with that regard. I do the exact same dissection that I do open. So if it's an adenocarcinoma of the pancreas, I'm right on the SMA, right to the adventitia, taking every bit of tissue along with that uncinate, every bit of uncinate tissue. For something if it's a IPMN or a benign lesion, a couple times I've left a little bit of uncinate, but once you get the technique down, it's really easier to just go right up the SMA. So I do a full uncinate dissection and just a lymph node dissection around that, regardless of the etiology.
Next microphone.
Mike Ron Martin, Marshall, Wisconsin. That's a truly exceptional presentation. I didn't happen to catch you mention in any of the studies you presented or your own what the conversion rates to open are during the procedure.
Yeah, and for the assessment of what the value of laparoscopic pancreatic duodenectomy is, I purposely, and there was a little footnote on that slide, I excluded their conversions in those studies. So the numbers I showed you were just for the ones that were completed. We've converted 3 patients out of the 60. One of those was initially planned. It was what I kind of recommended. We did the resection first and then just opened for the reconstruction, so preoperatively we planned that. And then I've had 2 patients where we've explored to the point where the vein was questionably involved with tumor, and so we converted to an open procedure and did a vein resection. But other than that, we haven't had any conversions for bleeding or any other complication.
Rich?
I did. It's 17% in our series, which is a little higher than I would like it, still within kind of a reasonable range. I don't know if that's so much technique, because it really hasn't changed from the first 30 to the second 30 we did. If it's patient selection bias, we're comparing that now, but it seems like we have a lot of patients with the risk factors, the small duct, soft pancreas. So I don't know if that adds to it or if it's just 17%.
Richard?
Michael, that's a real tour de force, and I'd like to congratulate you on that. I'd like to deal with your patient selection, and it seems like you have a very select group. So one way of getting at that would be, what's the percentage of Whipples that are being done at the Mayo Clinic laparoscopically? Secondly, do you handle patients who've had prior upper abdominal surgery, whether it's gastric or so forth, that you're going to expect a lot of adhesions? You did talk about obesity, but it seemed like in the video, and maybe just because the video, that omentum and intra-abdominal fat was much less than we often see in doing our pancreatic resections. So if you could deal with those, I'd be interested. Sure.
The first question, Dr. Prinz, was?
Selection percentage.
The selection percentage. More detail.
What percentage of total Whipples?
Oh, yeah. I wish I had that number. I don't. These 60, we've done, the first one was September of 2007, so or July, I'm sorry, so almost 2 years. And, that probably represents a quarter, maybe less than that, of what we do laparoscopic. In my own experience, during that 60, I've probably done 45 or so open. When we did the first 30 and I look back, I'd actually done 30 open. And so in terms of the selection, though, many of those were questionable vein involvement, several were vein resection, things like that. But with the upper abdominal surgery, I guess I don't think I've had one recently that's had a gastrectomy or anything like that. Certainly have had patients with open cholecystectomy and different operations, but not had that deter us from doing it laparoscopic.
We'll let Mark, one of our local arrangements hosts, have the second to last question, and we'll let your new neighbor in Milwaukee and a leader of this organization have the final word. Mark?
Thanks, Keith. Just again, another compliment on your immense skills. It's very humbling to watch you do this. For those of us that are about to embark on this learning curve, the robotic surgery, if you talk to any of the Da Vinci sales reps, they will tell you that these operations will be immensely easier to learn if you can learn them with the robot. And I don't believe that, but I know there is pressure to incorporate robotic surgery as a means to facilitate this type of procedure. I'd just like your impression and your general thoughts on that.
Yeah, that's a really great question, actually, because I think we've done 9 of these with Da Vinci assistance. My concerns with the Da Vinci are the lack of haptic feedback. You know, I've done several other procedures with the Da Vinci, and with time, I don't know if you've heard the rumor, but it's true, with time, I think your other senses dig in, and you can almost swear you feel sometimes, but the haptic feedback's not there. To be honest, at least at this point, the Da Vinci slows me down personally with the setup and everything else. I don't find that much. What I do find with the Da Vinci, though, is you really don't have to know, you don't have to have the advanced laparoscopic skills as much. It's much easier. I can have a resident sit down and sew the duodeno J and look good doing it with the robot, and it'll take them 15 minutes to load the needle up freehand with a driver. So clearly it's easier to teach and easier to learn for someone that doesn't have laparoscopic skills. So I wouldn't be surprised if we're still doing lap Whipples in 5 years, that most of them are going to be done that way. But I personally have some reservations with that lack of haptic feedback. I don't really buy that the 3D adds much to the visualization. With the magnification alone, I feel like I see the duct and everything just as well. But that's my personal opinion.
Doug, the last question.
Well, I'll ask the question that everyone is probably thinking about. I'm the one stupid enough to ask it. But how do you get at the ethical issue of the learning curve? I mean, because you even admitted to your learning curve as someone who's super skilled was significant. What about, you know, what are we to do when a case may be going that takes 10, 12 hours, the patient has a postoperative pancreatic leak, and then, as you admitted, Mike, you kind of hand-picked the cases that did not have mesenteric or root of mesentery extension, et cetera. So that would be number one. Number two, the ACOSOG trial is now requiring photographs, and we certainly had plenty of talks earlier today on the issue of local recurrence and the importance of the SMA margin. Are you completely comfortable that that what you've done is translatable necessarily to other surgeons? And just as a side comment, I know you picked that video to show an IPDA. That was still a very big IPDA, and that's someone where I'd be worried about median arcuate ligament syndrome, celiac compression, etc. But I think those two issues: one, the concern over the learning curve, and number two, whether the SMA dissection can truly be translatable outside of a high-volume center where the technical excellence exists. But your videos were great.
Yeah, no, it's a great question. And I guess if I had one disclaimer, it would be the amount of laparoscopic experience I had before I did this, which may not be translatable to the standard HPB surgeon, because you just don't get that much laparoscopic experience. What I would say is, you know, it may be a stretch to go from doing being an HPB surgeon doing lap spleens to doing a Whipple. I don't know that would be appropriate. If you have the laparoscopic skills and you're doing a lot of things laparoscopic and a high volume of it, I think you're probably going to be in a better position to get to this point. With that said, many of us do laparoscopy before certain cases, you know, to dissect a little bit further each time over time, I think would probably be at least appropriate for the resection phase. The reconstruction phase, I think you probably are going to need to be doing other things laparoscopic, such as bowel work, bowel resections, and sewing it back together before you try to sew the pancreas. So the translational point. And in your point on that paper, yes, that was beautiful, big vessels. No, she had no problems, as you suggested. We were just that fortunate.
I think we're going to have to wrap it up. Thank you very much, Mike.